Welcome to the McMaster University Demystifying Medicine Seminar Series. I'm Branson.
And I'm Pavitra.
We are continuing with our series based on Dr. Norman L. Jones' book titled The Ins and Outs of Breathing.
Today, we're going to be looking at part 2 of chapter 20, Breathing Smoke and its Consequences. We'll cover emphysema and chronic bronchitis in depth, looking at these illnesses from various perspectives, examining causes and clinical symptoms, and tying it together with a note about chronic obstructive pulmonary disease. Let's get started.
An introduction to emphysema. Emphysema can be translated to blown up in Greek. Matthew Bailey was the first person to have published information regarding pulmonary emphysema by postmortem examination of the lung of Dr. Samuel Johnson. Another individual named René Laennec concluded that in emphysema patients, air leaves the alveoli slower than what would be seen in a healthy patient. Moreover, Laennec had arrived to a conclusion that the deterioration of alveolar walls along with the increase in size of the alveoli was related to emphysema. Ultimately, it is important to note that destruction of alveolar tissue is integral to the characterization of emphysema.
Causes of emphysema. The causes of emphysema were actually found by surprise. Swedish physicians Carl Bertil Laurel and Sten Eriksson observed low levels of the blood plasma protein alpha-1 globulin in 2 emphysema patients while studying the variations of the protein's concentration. At the time, it was known that alpha-1 globulins were potent inhibitors of trypsin, an enzyme that breaks down dietary proteins. Another chance discovery was also made by Laurel when he found that increased breakdown of lung tissue protein may be correlated with emphysema development. In particular, he found that 80% and 50% of males and females, respectively in families with a severe alpha-1 antitrypsin deficiency, developed emphysema. Alpha-1 antitrypsin is a serum trypsin inhibitor. As such, his results suggested that emphysema was a result of activated leukocyte-produced proteinase activity on alveolar wall elastic fibers.
In healthy individuals, enzymes such as elastases produced during inflammation are rapidly inactivated. However, in those that lack alpha-1 antitrypsin, inactivity is limited. Thus, the enzymes are more activated, leading to a loss of elastic tissue, breakdown of alveolar walls, and expansion of lung air spaces. Leukocyte activation can also be caused by both cigarette smoke and air pollutants.
An introduction to chronic bronchitis and its history. One of the earliest descriptions of the effects of chronic bronchitis was characterized by Charles Badham. He described it as an inflammatory affection of the part of the mucous membrane which lines the bronchial tubes. A few decades later, William Stokes came up with the term chronic bronchitis to label patients who persisted with a productive cough with no apparent cause.
In 1932, Howard Florey identified enlarged mucus glands and overproduction of mucus as the causes of chronic bronchitis. However, the most precise description came about in the 1950s when Lynn MacArthur Reid showed that the enlargement of mucus glands caused airway narrowing and was associated with chronic inflammation of the bronchial wall.
Chronic bronchitis and emphysema. A comparison. The incidence for emphysema was much greater in the United States than in Britain, and vice versa for chronic bronchitis. Patients in clinics from the US and Britain were followed for 5 years, but there were no notable differences between the two groups. However, when some of the patients died, scientists were given an opportunity to examine the lungs to see physical differences between emphysema and chronic bronchitis.
Patients with bronchitis and severe airway obstruction tended to be overweight. Their lungs typically had a normal size and elasticity, but had low blood oxygen levels. Low oxygen levels constricts blood vessels, causing increased blood pressure in the pulmonary artery and water retention in the kidneys. Both of these physiological changes leads to symptoms such as swollen legs and an enlarged heart, and eventually features of heart failure. On the other hand, patients with severe emphysema were extremely skinny and always short of breath. Their lungs tended to be larger but inelastic, and surprisingly, the patients could maintain normal blood oxygen levels at rest. Nevertheless, during exercise, blood oxygen levels would fall drastically. Despite such striking differences between the typical emphysema and the typical bronchitis patient, there are many occurrences of both disease manifesting in the same patient.
COPD. What does it mean? Chronic obstructive pulmonary disease, or COPD, is a term that was first used in the 1970s to refer to chronic bronchitis and emphysema together, sometimes referring to asthma as well, since the clinical picture for these may overlap. Using a general term also works because treatment addresses the effects rather than the underlying cause. A couple of large studies have shown that giving long-term oxygen treatment for patients who have reduced blood oxygen saturation helps to increase their life expectancy by 5 to 6 years. Many efforts are focused on improving quality of life for the patient, for example by encouraging quitting smoking and physical rehabilitation, since treatment options aren't many.
Patients with COPD have a lowered breathing capacity and an increased breathing demand, which can lead to them feeling very breathless when they exert themselves, sometimes up to 10 times as high as normally experienced. The lungs' structural changes lead to airflow resistance and require greater pressures to move air. The lung loses its elasticity and becomes overexpanded, meaning more effort is needed to breathe the same amount of air as would be needed normally.
Summary of the current situation in smoking prevention. So we've established throughout this chapter that the more cigarettes smoked, the faster the lung disease development. As a result of public anti-smoking campaigns, the prevalence of smoking in Canada has decreased from 50% just a few decades ago to 19% within the last decade. It's especially important for young people to take notes of the effects of smoking, since they've been identified as a population in which smoking prevention efforts are progressing slowly.
With further effort, we can work towards greatly decreasing the prevalence of smoking around the world. This concludes part 2 of Breathing Smoke and its Consequences. Be sure to follow our videos and subscribe to the McMaster Demystifying Medicine channel for more interesting videos.
This is Pavitra and Branson signing off. Thanks for listening.